Today we're going to have Mr. Samir Matloob speaking on the topic of surgical management of brainstem cavernomas. So Mr. Samir Matloob is a consultant neurosurgeon at Oxford University Hospitals Trust, which is actually my local hospital. And he has a subspecialty interest in neurovascular and skull-based neurosurgery. He qualified and trained in London, ranking first in the UK as he entered neurosurgical training, and was subsequently awarded the Junior Barrow Travo Fellowship. He trained at Imperial, UCLH, Great Ormond Street and Barts Health, and he went on to complete fellowships in skull-based surgery and vascular neurosurgery in Cambridge before being appointed directly into a substantive consultant post in Oxford. Impressive track record there. Samir has one of the busiest neurovascular practices in the UK and is co-director of the Oxford Neurovascular Fellowship and is a fellow of the Royal College of Surgeons of England. Samir has a keen interest in medical education and training, and that's so important for the next generation. He is the director of the Oxford Junior Clinical Fellow Programme in Neurosurgery and continues to publish his research in neurosurgical journals, as well as presenting regularly at national and international meetings. So, Mr. Matloob, thank you so much for joining us today. I'm now going to pop a spotlight on you and hand over to you. We're really looking forward to your presentation.
Thank you, Helen. That's a very kind and warm introduction, and thank you for inviting me to give this talk. I have to say I'm already very impressed with the attendance from all over the world. It's very exciting to see so many people from all over the place log in. Can you see my slides?
We can.
Perfect. So yeah, as you very warmly introduced, my name is Samir Matloob. I'm a consultant neurosurgeon from Oxford, and I'm here to talk about mainly the surgical management of brainstem cavernomas. I'd like to cover a little bit about cavernomas and very briefly on brainstem anatomy, and talk more about the presentation and natural history of these conditions, and a little bit about the decision making, as well as the surgery, the indications, and a bit about the adjuncts and risks. And I'd like to get through and leave plenty of time for any questions. So if you feel like I've rushed through something, please do feel free to ask me to go back. As many of you are aware, cavernomas are clusters of abnormal thin-walled blood vessels. They're low-flow vascular lesions, and they have many other names in the literature, including cavernous malformations. CavMal is the sort of verbal abbreviation used largely in North America. Cavernous angiomas and CCMs are all used in the literature, and they have this mulberry type appearance, and these are cysts essentially filled with blood, thought to be towards the venous end of the spectrum of vascular pathology, but it's really sort of dilated capillaries within the parenchyma of the brain. Now, I'm not going to go through all of the brainstem anatomy because that is a talk in itself, but we are considering everything from the thalami, which are the deep grey matter structures in the cerebral hemispheres, down through the midbrain, the pons, and the medulla. These are where all your cranial nerves that control many of the functions of your head and neck come from, as well as the way in which your brain communicates with your spine and the rest of your body. So a lot of densely packed important structures and some real important clockwork in this space no bigger than the size of your little finger. The most interesting thing about cavernomas, and particularly in the brainstem, is they're basically the only time in neurosurgery where you will see a bleed into the brainstem in a patient who is still awake and able to communicate and neurologically accessible. Generally speaking, all other causes of bleeds into the brainstem, particularly large ones, are associated with a poor outcome and certainly with a poor neurological deficit. This means that patients with cavernomas can present in more interesting ways with cranial nerve palsies and transient neurological deficits. They can occasionally present with drowsiness and headaches, but what you must remember is that headaches in particular are a very common symptom caused by many, many things, and um, some and cavernomas are very frequently found as incidental findings on scans, so the two are not always related. The pictures I've put up here are examples of patients who have brainstem cavernomas that symptomatically appear to have bled, but these were managed conservatively. And despite some of these patients deteriorating, they recovered their neurological deficits without any intervention at all. And you can see with the scan of the patient towards the right of the screen, that's a fairly sizable mass to be inside the brainstem of a patient, but didn't actually require any intervention. By contrast, these are some patients who I've treated over the last couple of years who have had cavernous malformations, cavernomas that have outwardly bled into the surrounding brain. Um, these are a slightly different kettle of fish and have been associated with much worse neurological deficits. And in many cases, in fact, in all of these cases, there were repeated episodes and repeated bleeds that resulted in us making the decision to operate on these to prevent any further neurological deterioration. The understanding the natural history has been the subject of many papers and many publications on cavernomas. Ultimately, it's difficult to know and predict which cavernomas are going to bleed and which ones are not. There are some risk factors, including the size of the cavernoma, association of a developmental venous anomaly, and younger patients are all more likely to have a symptomatic cavernoma that bleeds. We know that cavernomas that bleed are more likely to bleed again as well. And in the deeper structures like the brainstem, the bleeding risk is considered higher, and really the percentages vary from sort of 7 to 8% per year following a bleed. And in some other papers, they've sort of quoted a sort of 30% rebleed rate. So there's some variation in the percentages, but ultimately the decision has to be on an individual basis and it has to be on clinical grounds. So I wouldn't use the statistics really to say definitely whether someone needs surgical treatment or not. We know that with many of these patients, there are multiple cavernomas and there are genetic causes for cavernomas as well, which I'm sure is something that many of you listening today are already aware of. And these also have to be taken in consideration as a separate entity as well. So the data is not clean or clear by any stretch of the imagination, but there's more and more information coming out that is helping inform the natural history and the treatment options. And these are all kind of used to advise patients and families in clinics as to trying to predict the future, although unfortunately none of us have a crystal ball, which would make my job a lot easier. In Oxford, we run a specialist MDT, which stands for multidisciplinary team, which involves myself, my neurosurgeon, one of my other neurosurgery colleagues, radiologists and neurologists who specialize in vascular pathologies. And the vast majority of things that get discussed in the multidisciplinary team meeting are incidental findings of cavernomas and what features may increase or decrease the risk and what kind of treatment, if any, we should be thinking about. But most of all, it's a question about, should we be monitoring this? Do we need to repeat further scans? And practice is still quite heterogeneous, but I'm proud to say that through setting up a specialist clinic for patients with cavernomas, these conversations are becoming more standardized, and we're gaining more and more interesting data as to um, which patients we monitor, which patients we go clinically on. And what I mean by going clinically are patients who develop symptoms and at that point get scanned. We have to look at the scan, we have to look at the clinical symptoms, and we have to look at patient factors and age and general overall health as well. And all of these are individualized to the patient. It's important to note that it's rare, but some cavernomas do grow, and some cavernomas only present with seizures, and some bleed and cause neurological deficits. And there are a few that cluster bleed, which I'll go on to talk about in a moment. Ultimately, the decision making when we're talking about surgery is, do we think that the chances of doing harm by trying to treat someone, and in the context of brainstem cavernomas, that risk is high? We're talking about operating in a very eloquent area of the brain that could have disastrous consequences if damage is done, versus the natural history. Are we going to be successful in preventing further bleeding of this cavernoma? Are we going to be successful in preventing any further neurological deterioration? And this decision-making balance will vary based on the history so far. So someone's chance of doing harm versus their prevention will change with time. If they continue to bleed, then that adds a bit more weight to needing to do something about it. In terms of when are we going to decide, when we finally decide that actually surgery is the right way to go, it's a big undertaking. So it's not about going sort of half in. If you're going to go for surgery, it's something that you're going to really go for. And this is a character who I'm sure all of you have great respect for in terms of decision making and intellect. The things that make us lean more towards surgery for brainstem cavernomas is if the cavernoma's already done the work of dissecting itself out. So cavernomas that bleed outwardly, and I can go back to the scans I showed you earlier, they can present themselves to a surface that is surgically accessible, which prevents us from having to make cuts into the brainstem and in an attempt to get to the cavernoma. And these are what I mean by exophytic cavernomas. When a cavernoma bleeds and bleeds and continues to bleed repeatedly, these are distinct clinical episodes associated with scans that show further bleeding of a cavernoma. These are usually a good indication as well to try and arrest the progression of a cavernoma causing more neurological injury as time goes on. And that kind of ties in with worsening neurology. It's a combination again of the scan and the patient. And if someone is developing symptoms that are worsening, for example, repeated episodes of drowsiness, or repeated neurological deficits or weakness, these are indicative of something that we need to get involved with. It's also worth mentioning at this point that most symptoms caused by a bleed from a cavernoma, because they are low flow, a lot of the symptoms resolve. So people with cavernomas might have a bleed and have symptoms, but actually by the time I've seen them in clinic or by the time they've presented to the hospital or a few days or weeks have passed by, the irritation to the surrounding brain has resolved, and actually the neurological deficit has resolved as well. And so that also needs to be taken into consideration. What I meant by worsening neurology is people who don't quite get back to their baseline and continue to have problems. You'll see a lot of things in papers and textbooks about safe ways of getting into the brainstem. The honest truth is, it's better to not cut into the brainstem in the first place. But if you have to, the approaches to reach different parts of the brainstem are all different skull base approaches. So you can see with the image on the right, the approaches to the higher up part of the brainstem, so the midbrain approaches, can be done through a superior cerebellar infratentorial approach, which means going above the cerebellum and underneath the tent, which is a membrane that separates the supratentorial compartment from the infratentorial compartment. To get to the back, you can go subtemporal, which is what ST stands for, and then the anterior midbrain approaches are pterional, orbitozygomatic, or mini orbitozygomatic. These are approaches basically from the side of the head coming in over the eye to try and get to the front of the brainstem. These are all challenging approaches where you're working at quite a deep depth to get to the cavernoma. So you'd like it if the cavernoma had done some of the work for you as well. As you go lower down, some of them are similar approaches. So subtemporal, transtentorial there, retrolabyrinthine or retrosigmoid approach gets you into the space between the pons and the cerebellum. There's a cerebellopontine angle where a lot of important anatomical structures can be found, but is also a good approach to getting really round to the side and almost in front of the brainstem in some cases. And from the back again, suboccipital telovelar approaches where you're going in underneath the brain to get to the lower lesions, which you can see at the bottom there as well. And FL there is far lateral, which is basically a modification of the retrosigmoid approach where you can get a bit more anterior by drilling off a bit more skull. Sorry. When we operate, there are several adjuncts that one can use to try and improve the safety. This isn't just necessarily for brainstem cavernomas, but for a lot of neurosurgical procedures. The imaging and technology has improved significantly over years and decades and is a really expanding area of industry. So navigation provides us with a GPS type approach to mapping out and planning approaches in neurosurgery. Intraoperative ultrasound can be very useful to get a real-time picture of where you are and looking through the brain once the bone is off. But neuromonitoring for operations in and around the brainstem is critical. It tells us how much, or it can tell us how close we are to certain structures and tracts. It also tells us how much irritation to cranial nerves and to the brainstem has been caused, and can give us some idea of when we could potentially might need to stop to prevent any further deterioration. And leaving residual cavernoma behind, although not ideal, is sometimes the best possible outcome to prevent neurological deterioration. And a decent microscope, you need to see what you're doing. There are a lot of risks of not just brain stem surgery, but brain surgery. Any operation, whether it's an appendicectomy under general anesthetic or a brainstem cavernoma, has risks including infection, bleeding, risks of the general anesthetic, blood clots, as well as damage to any surrounding structures and failure to achieve the desired goal. When you're operating in the brain, not so much for brain stem surgery, but higher up there's and the additional risk of seizures. But with brainstem and all brain surgery, there's a risk of stroke, a risk of bleeding, and permanent and temporary neurological deficits. In the posterior fossa, where the brainstem sits, um, there's a risk of injuring the cerebellum, causing posterior circulation strokes, but also any swelling in that area could be life-threatening. And also leads to a condition called hydrocephalus with a buildup of CSF and a buildup of pressure within the brain that may result in needing further surgery. And any surgery on the brainstem is going to carry risks. And depending on where you are in the brainstem, that can be anything from problems with vision to problems in your upper and lower limbs to difficulties with breathing, and even the basic functions of the human body are at risk with any operation in and around the brainstem. So it's real tiger country. That kind of covers a lot of the stuff I was going to talk about in terms of open surgery for cavernomas. There was a video that I was going to show, but if I'm being completely honest, the quality of the video that I had is it's difficult to make out any actual real anatomy because it's really just zoomed in on the cavernoma and dissecting it away from white matter. So I didn't feel it was had a huge amount of utility there, but I hope I've made the point of surgery and the risks associated with it, and in which cases we are more likely to intervene. I wanted to make a couple of comments about radiosurgery and gamma knife treatment, which is an area that is and there are obvious attractions towards treating cavernomas through a non-invasive way and avoiding all of the risks and things that I've been talking about. And there is promise here, and there are centres within the UK that are doing gamma knife treatment for cavernomas with some promising results, but the evidence is limited. It is largely observational and retrospective data that's in the literature. And I think if you have a cavernoma and you've been told it's not surgically resectable or it's too high risk, and it's causing symptoms or problems, then it can be considered. And I sort of reserve full judgment to those who perform gamma knife treatment, and I wouldn't dare quote their success rates, but I think it's something that can be looked into. The idea is that it reduces the rebleed rate after 2 years. So, like with everything that stereotactic radiosurgery or gamma knife treats, the effects are delayed. The problem is, unlike other vascular problems, where you can see an improvement in the imaging over time, the cavernomas tend not to actually, you don't see much of a radiological improvement. The argument is that the clinical episodes are reduced, but we struggle to know the exact clinical course of most cavernomas anyway. So trying to find significance in that, I think, is a bit tricky. We know that in terms of these outcomes of rebleed rates, there's not really been any superiority shown between stereotactic radiosurgery or open surgery based on the information available. And again, this is still fairly limited, but there is more and more coming out with every year that people look into this. It's also not been recommended in patients with familial cavernous cerebral cavernous malformations, and actually we know that radiation treatment can be a trigger for cavernoma formation, and so and particularly in familial cases, the evidence still isn't there either. But I know that there are lots of people with different views on this, and I'm very happy to discuss. I think I've just coming up to about half an hour now, so I'm glad to say there's plenty of time, hopefully, for your questions. I have left some email addresses there if anyone does want to get in touch for clinical opinions, which involve reviewing scans and things in terms of private referrals. That's something that can be done outside of this. I'm sure Helen will cover this, but I can't really give detailed medical advice without reviewing everything in a more formal setting. But I'm very happy to take any questions about what I've talked about. Yeah, Helen, over to you.
Fantastic. So, Mr. Matloob, if you don't mind just stopping screen sharing, I just want to say thank you so much for a really informative talk. I've watched a lot of presentations, and every time I take away something new, and the thing I jotted down was that phrase, cavernomas can have done some of the work for you. And that was something I wasn't actually sufficiently familiar with, that when they bleed out, that can make them present in a way that means they're more accessible to surgery. So that was my new fact that I've learned today. And on the neuromonitoring, just to share with people, Axiom Neuromonitoring is an organisation who have undertaken monitoring for brainstem surgery, and their CEO Dale Derbyshire was so inspired by some of the surgery he's been involved with that he actually now funds our counselling service at Cavernoma Alliance UK. So it's just lovely seeing the way all these pieces fit together. So we've already had some questions come in, but just in case you've not yet put your question in the Q&A, if you wiggle your cursor at the top or the bottom of the screen, you should see the option. It's a little speech bubble with a question mark in and Q&A. Do pop your questions in there, and I can see we've also got some in the chat, so I'm going to make sure I pick those out. So the first question that we've been asked is, how many people do you see in your clinic each year who have brainstem cavernoma? And I can imagine a lot of people are wondering, how common is this? And for you personally, is this something you're seeing a lot of?
So the way I know there's people from all over the world here. Sorry, I just saw. Thank you. Um, uh, the way healthcare systems work from place to place varies. In the UK, we cover, so Oxford covers a population of about 3.5 million. And so there will be neuroscience centres dotted around the country that cover fairly large population areas that will get referred these cavernomas in. We obviously have an interest and have developed the service a bit more, and so sometimes we get some referrals from out of the area as well. The MDT goes through, and it's every week, and we normally see about 7 to 10 cavernomas in the MDT. Most of these are cerebral cavernomas in different parts of the brain, but I would say at least 1 or 2 a week that come through the MDT have been referred because they have a cavernoma in the brainstem, and some patients have multiple cavernomas, and one of them may be in the brainstem as well. So we tend to see these patients. I wouldn't say we see one new patient a week in the clinic, but certainly probably every couple of months, a brainstem cavernoma that's new will have presented itself that we then see in the clinic and give advice on.
Thank you so much. That was a really comprehensive answer. And you were saying there how we've got people from all over the world. I jotted down Egypt, the US, Ireland, Canada, Pakistan, India, and Germany. And they're just the ones who've said hello. So it's extraordinary how many people have joined. And I know some of you today may never have spoken to someone else who has cavernoma. And it may be really hard to access information in your home country. So we're so glad you could join us. So another question building on from that, and that is, roughly what proportion of the symptomatic patients that you see with brainstem cavernoma are you treating surgically versus conservatively. And conservatively, that term is used in respect of non-surgery, so treating things like symptoms for people on here today who are not familiar with that term.
Yeah, so the minority. It's very few patients are present with a brainstem cavernoma that repeatedly bleeds to the point at which we feel that it's lower risk to intervene with a big operation. We are referring more patients for consideration of gamma knife when we feel that surgery is just too high risk for patient factors or because it's something that's really quite inaccessible. But it's if we see, let's say, a brainstem cavernoma once a new brainstem cavernoma once a month for a year, I would guess probably about one of them might need an operation.
Thank you for sharing that. And to share, we will shortly be doing an announcement on our social media that actually two new centres are offering radiosurgery. So historically, that's just been the National Hospital for Neurology and Neurosurgery in London and then Sheffield, but actually Bristol and Leeds are now also commissioning those services. They're just getting started, but those are now going to be available for referral through your neurosurgeons, making it a bit easier because we know for some people it's been a real long journey when it's been determined that that's the right treatment for them. We're getting a lot of questions in here, which is amazing. So I've got many more to go through. So the next one is on the slides where you were showing the cavernomas, what sort of sizes were you talking about? So someone wanted to get a sense of the scale, maybe if you want to say in centimetres or millimetres.
Yeah, so the ones that you saw that were operated on were probably all more than a centimeter. Um, so most of them are probably about between 15 to 20 millimeters. It sounds small, but we are talking about small structures. So it's if you see a white blob inside uh, the grey blob that is the brainstem, and it's causing a lot of shift, or it's opened up a space into the subarachnoid space, which is how we can get to it. That's what I meant by sort of doing the work for you. The actual cavernoma inside that blood clot is usually small, is obviously smaller than the blood surrounding it. But the lesion itself is not, often no bigger than 2 centimeters. Um, Obviously, higher up where there's more space, you can have cavernomas that get a bit bigger than that, but it's rare for them to get bigger than 2.5 to 3 centimeters.
And thank you so much. And just say we're getting some lovely comments in the chat. Somebody just shared, I can tell you work alongside people with cavernoма. Your talk is on point, lovely talking speed, easy language we understand. And I want to say thank you. And somebody, a parent of a child that you've operated on, has also said hello and thank you as well.
I
Just
saw
so
that, yeah. He's one of my star patients.
Oh, it's lovely to see, and we're really glad his mum can join tonight. So the next question is, what is the survival rate for brainstem cavernoma surgery?
Um, so the way I would answer this is it takes a lot to decide to go in to surgery. I would say that the chance of death, so when you say survival, the chance of death as a result of cavernoma surgery in the brainstem is thankfully very, very low. But these are very rarely performed operations as well. The main risks are more that you're unable to remove all of it safely. And so there is a persistent bleeding risk that does sometimes happen, unfortunately, or causing neurological deficits. To cause, thankfully, I've not had any experience of patients dying as a result of brainstem cavernoma surgery. Um, and I've not, even when you don't operate, it's rare for someone to die as a result of a bleed in their brainstem from a cavernoma. And in fact, I can only remember one patient who became unconscious as a result of repeated cluster bleeds from a rather large cavernoma that wasn't in the brainstem. It was somewhere else in the brain. They had an operation and they woke up and they were okay. But that's the most obtunded I've ever come across anyone from a cavernoma bleed.
I
So
think
very rare, thankfully. Yeah.
really helpful to have that reassurance because it's naturally very worrying when someone gets a diagnosis. And I think the point you made earlier as well about these being slow flow bleeds. And for many people, you do see good recovery from the point where they've had the bleed to when they come to you. And that period of time, it's amazing how much people can recover and
Yeah.
those logical deficits can improve. And we're conscious that's not the case for everyone, but it's good to hear that can be the case. So the next question is asking for your thoughts on pregnancy, hormones, and bleed risk. So we know many women within the community were interested to see a paper published by Von Zubier and Kelly Fleming to do with, it was a small scale study, but looking at increased risks associated with hormone replacement therapy and oral contraceptives. So it's a hot topic. And people are also saying, well, what about when you're pregnant and your changes in hormones then, if there's a risk associated with hormone replacement therapy and oral contraception? So just wondering what your thoughts are on that.
Yeah. So I get asked this a lot, particularly with regards to pregnancy, not just from patients, but from obstetricians who want more information. We have looked into our experience in Oxford and found no significant association between cavernoma bleeds and pregnancy or hormone replacement therapy. This is obviously just single center data, but also the published literature that I've come across, there's no convincing argument to say that actually there is a significant increased risk with pregnancy, hormone replacement therapy, or anything. We know that with other vascular abnormalities of the brain, um, that we do see, um, largely because of physiological changes in pregnancy, and particularly in childbirth, there's thought to be an increased risk of high flow vascular problems being more of a problem. But even then, the data for it is very weak. And so we've had a discussion about this within our own neurovascular group meetings, and the sort of response rates were quite variable in terms of what advice you would give. My view and the advice I generally give is actually there is no good evidence, and therefore, if you are symptomatic, requiring hormone replacement therapy, or if you're planning a family, then you should do those things. And I think the risk is actually very low of it affecting your individual specific outcome, but that's within the limitations of the data we have available.
Absolutely. And just to say, the advice you're given in terms of pregnancy very much echoes the advice we give through our advisory board. And I've just pasted into the chat there, we have a leaflet for people who are thinking about getting pregnant or are pregnant. We've also got guidance linking through to a study in respect of hormone replacement therapy and oral contraception. But as Mr. Matloob just said there, that study was one study. It's small scale. More research does need to be undertaken. And at the moment, it's not the case that it's considered contraindicated. So HRT and oral contraceptions are still being prescribed to people with cavernoma, and there's lots of different factors to consider. So always important to act on your individual clinician's advice. So the next question we have, approximately how many neurosurgeons in the world actually have brainstem cavernoma as a subspeciality? And they say apologies if that's not quite the correct wording. So I think they're really interested to know, is this a small group of people or is it a large group? Just trying to get a sense of it.
Difficult to comment for around the world because there are very varying healthcare systems, and the ratio of neurosurgeons to the general population varies quite a lot as well. So um, I think Japan actually has the highest number of neurosurgeons per population. Um, the UK, I think, is not at the bottom, but it's much closer to the bottom. Um, and if I sort of said there's about 500 consultant neurosurgeons in the UK across about 25 odd units, and in each unit, this is the kind of thing that you'd expect only one or two surgeons to perform. It is very much low volume and high complexity, and that's an area that, particularly within the UK and NHS commissioning structures, is something that it's one of those things that you'll have a subset of surgeons doing it. It's hard to put a number on it. I would guess in the UK, um, it's somewhere in the region of about 50 surgeons that would do this. Um, and again, they may be vascular surgeons and skull-based surgeons like myself, or there may be sort of pediatric neurosurgeons with them who have got a wider interest in this. And also the way subspecialization has kind of developed in neurosurgery means that your older generation neurosurgeons will have done more of this just because they had a much more varied practice, and we're now clinical practice is kind of more narrowed into specific subspecialties, which brainstem cavernoma is likely to fall into vascular more than anything else, I would say.
Thank you. And everyone, just to let you know, I've got 15 questions left, and I'm conscious we've got 15 minutes. We may not be able to get through everybody's, but what I'm going to do is take them in the order that they came in, and we'll try and get through as many as possible. So, the next question I have is, you talked about familial cavernoma, which for those who not know that term, that's when it's inherited. And that affects around 1 in 5 people with cavernoma. And somebody's asking the question though, well, how would you know if your cavernoma is inherited or if your cavernoma is sporadic? And sporadic means it hasn't been inherited.
Okay, I'll try to answer questions faster. Um,
Please take your time. Some of the questions are duplicates as well, people asking the same thing. So we welcome the depth that you're giving.
so familial are usually multiple and usually present in younger age groups, but there are specific genes that you can look for to know whether something is familial or not. So genetic testing can be performed if there's a suspicion that there is a family history of cavernomas, but essentially older patients, so adults with a single solitary cavernoma, are less likely to be familial, and I wouldn't routinely offer genetic screening or counseling or anything. Um, and those who are younger with multiple cavernomas, much more likely to have a familial background. You take more of a history, and you refer for genetic testing.
And thank you. And so, a question a few people have asked, and I know you touched on, but I think it'd be really helpful if you could just repeat the figure. People are wondering how much more of a risk is it if you've got a brainstem cavernoma? So, if you've been newly diagnosed with a brainstem cavernoma, what's the bleed risk for people?
So I'd say it's about as high as 30%, based on the the literature that's most often quoted. Um, does it mean that a cavernoma, if you take the same cavernoma and put it in the right frontal lobe, and if you put it in the brainstem, a bleed in the brainstem is going to be more likely to be clinically significant than a bleed in the right frontal lobe, for example. And so it's not just the bleeding risk, it's the symptomatic bleeding risk. So I would say actually cavernomas, most of them will bleed at some point, but most of them are silent bleeds with very temporary, if any, symptoms.
Mm, excellent, thank you. So the next question we have is around success rates for surgery. And again, I know this is something you've touched on, but if someone's wondering, what's the chances it's going to be successful? I know you've talked about many different factors, but is there an easy answer there, or is it really down to the individual presentation?
I think it comes down to exactly where in the brainstem we're talking about. Um, as I said, if we use a right frontal cavernoma as an example, although it's not in the brainstem, I would quote a patient that there's a high chance of removing all of it, and not having a problem with it afterwards. In the brainstem, because you're surrounded by much more eloquent structures, it's more difficult to get to. The chance of leaving a residual is higher. I don't have a good percentage for all brainstem cavernomas, and obviously it depends on how confident we are exactly where the cavernoma is within the blood load. Um, but all I can say is that that risk is higher, and that um, if there is a residual left, there's a smaller chance that it will continue to bleed. But it's something that, if anyone does an operation on a brainstem cavernoma and doesn't follow it up fairly long term, I'd be very surprised, because it's the sort of thing that we perform relatively infrequently, and is something that we want to keep an eye on long term. So there will be probably further surveillance in the context of someone who's had a bleed from a brainstem cavernoma and surgery.
And then we've got a few questions linked to this. So you mentioned in your talk about sort of a regrowth, and people are asking the question, is that always? Because actually, even though you might have thought you've removed the whole cavernoma, there's a little bit left, and it's that little bit left that's regrowing, or can it actually be totally resected and then it just grows again from that point? So people are just wondering a bit about that.
So my cynical view is, if it's regrowing, then something must have been left behind. And sometimes it's something so small that you don't see it on the post-operative scans. Um, I think often what happens is you follow up people with scans and it either stays the same, and then you're satisfied that there's probably nothing there, or there's a tiny area of uncertainty, and you keep going back and scanning again just to check that nothing else has changed. Ultimately, provided no new symptoms are occurring, then it's safe to say, well, we probably don't need to do anything about it.
When this question's been posed to other neurosurgeons, they've given a very similar answer to that. So, next question is someone's asking, can altitude be a factor in a bleed risk? And this question's often posed to us on our helpline for people flying or climbing mountains, and they're worried about it.
It's a very interesting question. And again, I don't have any robust data to back up what I'm about to say. But in the same way that I don't worry about women getting pregnant and living their lives, I don't particularly worry too much about getting on a plane, or doing things that people find, interesting and exciting, and living their lives. I I generally am an advocate for carrying on with life, as best you can, and as as much as you want to, and not letting a diagnosis of a cavernoma uh, hold you back from that necessarily. If you're going to have a bleed, or you're going to have symptoms, we don't know when that's going to happen. It could be in your sleep, it could be watching the television, or it could be climbing Mount Everest. Um, why not go for all three?
Absolutely, and that really echoes the advice of our medical advisory board, who say it's okay to fly, it's okay to climb a mountain. And actually, every year, first Saturday in June, we climb Snowdon together as a community. And if you're interested in that, do have a look on our website. So we've just got 9 minutes left, and we've got a few questions. And actually, I think we're going to get through nearly all of them, which is fantastic. So the next question is a practical one. So if someone's going into hospital for brainstem cavernoma surgery, how long are they going to be staying in hospital, and how long is the recovery period?
So almost by definition, everyone who has brainstem cavernoma surgery has some neurological deficit to start off with. It would be very unusual to operate on a brainstem cavernoma in someone with no symptoms. And because we're talking about brainstem symptoms, these could be problems with swallowing and eating, or they could be stroke-like symptoms and difficulty mobilizing. Therefore, in the context of the patients who we've treated, they've all had fairly long stays, because by the point in which we are considering treatment, they've already been admitted with symptoms to start off with. So their admission starts before they don't necessarily come in for a brainstem cavernoma operation. It's something that we've kind of in a position where we have to do. So the length of stay, I would say, is quite long, and it's very largely based on the neurological symptoms preoperatively. And obviously, if there is a complication in surgery or there are more neurological deficits postoperatively, then they have to recover from that as well. I think the quickest we were able to turn around one of our patients who was clearly having repeated bleeds, but at home, we admitted as an emergency. We were able to operate and get her out within about a week. And that was just because she was having repeated bleeds, but the neurological deficit was never so bad that she needed to stay in hospital for a long time.
And in our experience at the charity, it's amazing the recovery people can make. And we know it varies, and that's not the case for everyone, but it is an extraordinary where someone can be and then where they can get to. So next question is from someone saying, to what extent are UK neurologists familiar with cavernomas? And they're saying from their experience, awareness seems to be limited and not as much as they'd hoped for.
So, um, so there's neurologists and there's neurosurgeons. Uh, so most neurosurgeons will have some, and they're all in neuroscience centers, will have some understanding of cavernomas. But in pretty much every unit, there is someone who will have more of an interest, or they should be someone with more of an interest in vascular pathologies, which includes cavernomas. Neurologists are a much bigger group in the UK, and they have a huge range of expertise in different areas of neurology. And for them, actually, the management of cavernomas per se is not something that they're very familiar with. It's more they come across them because they're epileptologists, or they deal with seizures, and so a subset of seizure patients are cavernoma patients as well. And they might have some interest or understanding in the cavernomas, but less so. So it's more of a pathology that I feel should be referred through neurosurgical pathways, because you're more likely to find someone who understands the condition, and the treatment options really are do nothing surgery or radiation treatment when we're not talking about managing symptoms like seizures. And so if it's the cavernoma we're talking about treating, the people who treat them will be the surgeons. Sorry. What is that?
Excellent, thank you. And something we say on the helpline is it is okay to ask for a second opinion because symptomatic cavernomas is rare. And it can be the case that the hospital you're under the care of have very little knowledge of this. So don't feel you can't ask for a second opinion. It's not uncommon within the community. So we're just
Precisely, yeah.
coming towards the end now. We've got 5 minutes left. So I'm just going to ask the last couple of questions. Some really good questions here, and I know people on the webinar will have really benefited from it. So the next question is, how soon after surgery in the brainstem can scar tissue develop?
So my standard answer for scar tissue is 6 weeks. So a wound heals, the skin heals in a week or two. The tissue underneath generally takes a bit longer to scar up. In terms of going back in, you start to see, I mean, the brain tissue doesn't necessarily scar, but it gets harder and harder to differentiate, particularly in adult patients. when you go back in after a couple of months, things are already starting to change, and the longer time goes on, the more you see changes in the scans and intraoperatively if you do need to go back in.
So next question, what are the chances of a rebleed after a partial resection of brainstem cavernoma?
So quite a difficult question to answer. On the one hand, if you've had a cavernoma that's been operated on, it's likely that it's bled before, and therefore the risk, I think, is slightly higher of bleeding again, but you've reduced the volume of it, presumably, and there's a little bit left behind that it may remain indolent and not do anything forever, or there may be further episodes and scans which are then associated with more bleeds. I think the chance of it bleeding again is low, but not zero.
So next question, is there a cut-off size for brainstem cavernoma to decide whether it should be surgically removed or using radiotherapy?
Not really. I mean, small. I think the first thing to consider is should it be treated, and just because it's so. If you imagine a cavernoma as a sack of blood, sometimes what happens is when they bleed, they look bigger on the scan, and then you scan them again later, and they seem to shrink down again. They involute because the blood sort of breaks down around it. There is no strict cutoff in terms of size, but generally, the smaller a lesion and the more brain between you and the lesion, the less likely you are to offer surgery.
Next question, is Advil recommended for people with cavernoma?
Remind me, Advil is it paracetamol or I can't
I'm actually not sure. I'm not very good with brand names for
remember,
medications.
right. It's something that's in North America. I believe it's a trade name, I think, for paracetamol. Um, Paracetamol is fine. And again, there is no evidence that taking uh, anti-inflammatories like ibuprofen, if Advil is on ibuprofen or on NSAID, that increases the risk of bleeding. So as far as I'm aware, they're all safe.
Fantastic. So we've come to the end of our webinar now.